Hello, everybody. Now, today I'm talking to you about the common presentations in my patients. So, this is a day in a menopause doctor's. It's a day in a menopause doctor me. So, it's a range of patients ranging from age 39, and the oldest is 67. I've written some case notes here of what I've experienced or the cases that have come through for me to review today. So the underlying theme is tiredness, i.e. low energy, weight gain, libido, and a high cholesterol. Now, high cholesterol is a common symptom of perimenopause, menopause, because estrogen modulates cholesterol. Imagine estrogen being a conductor that tells lipids where to go and where not to go. So the LDL cholesterol is the lipid transport system to the blood, and the HDL is the lipid transport system out of the blood. So with perimenopause, menopause, the transport system to the blood, a lot of the lipids are directed to the blood and less are directed away from the blood. So high cholesterol is a result of that. Also, inflammation can increase cholesterol. Also, our eating habits can change because we're feeling tired all the time, we're craving sugar, or we just feel rubbish and we can start eating rubbish. But actually, for most of women, they are actually eating better than they've ever eaten, but they say that their cholesterol is getting worse. So if your cholesterol is getting worse and you're perimenopausal, then think about your hormones. Okay, number two, there was the tired all the time. Now, tiredness all the time can be caused by inflammation. And when we talk about inflammation, we are talking about your immune system. And the typical or the textbook reaction of an immune system is when you have a virus. The way you feel when you have a virus, it's not the virus, it's your immune system reacting to the virus. So when we go into perimenopause and menopause, because estrogen modulates your immune system, the fluctuation or drop of that causes an overactive immune system. It's like a guard dog barking at flies and insects instead of real threats. So then we have this immune system overactivation and chemicals being produced that are pro-inflammatory. So we end up with inflammation. We feel tired and achy all the time. So case 3, 39-year-old, her aim is, she says to me, I want to feel better. I want to get my life back. So in this case, when I see young women with severe symptoms, there's normally something else going on, and often there is neurodivergence. So there can be exacerbation of existing psychiatric symptoms like anxiety, depression, and ADHD. So for a lot of women with ADHD, they struggle a lot because their brains are already sensitive because of sympathetic overdrive, but also they are sensitive to fluctuations in hormones, in estrogen and progesterone. So with PMDD, it's really, really difficult to manage PMDD, really difficult. I should say that perimenopause, managing perimenopause is like chasing a moving target. But with PMDD, it's twice a moving target. It's just because it's really, really, the brain responds, does not respond well to fluctuating hormones. So PMDD management depends on the cycle. And I have written a blog on my website entitled Perimenopause, Master the Signature of Your Hormones and Titrate Your HRT According to Your Symptoms. I'll put the link on the video for you. So that is actually one of my most popular blogs, and I wrote it quite a few years ago, and I still see that it's effective today because estrogens goes up in the first phase of your cycle, so from day 7 to 14. And in the second phase, luteal phase, estrogen drops from day 15 and then starts picking up again at day 21. But the brain doesn't like that. So with PMDD, you want to even that out. Now with PME, premenstrual exacerbation, it is an exacerbation of existing psychiatric symptoms. So to manage that, you got to manage the existing psychiatric symptoms. Otherwise, if you don't do that, the patient doesn't do well. So what happens then is, for example, with ADHD, they'll speak with their specialist and they have immediate release dexamphetamines, which actually work, i.e., they top up their usual treatment in this second phase of their cycle when they have this exacerbation. But of course, the hormones are important as well. But it's not one size fits all. And a lot of these PMDD, PME women actually do not need a lot of hormones. In fact, they just need a stabilization that so that that up and down doesn't happen. But it is actually really satisfying for me to finally get these young girls feeling well. And they're usually in their 30s, early 30s, later 30s, and they feel awful. They feel awful. They are anxious. They're not sleeping well. They feel suicidal. And this is in the face that their hormones are shifting. Okay, then there was a case of a 61-year-old, and a main issue is vaginal dryness. This is vaginal dryness. And she didn't actually complain of any other symptom other than that. So why do we get vaginal dryness in perimenopause and menopause? Is it just lack of lubrication? So use a lubricant? No, if it did, then women wouldn't be coming to see me because nothing is working. So estrogen modulates collagen and elastin production. So that is the plumpness of your vagina, but also the glands that produce lubrication. So with vaginal estrogen, actually, it works really, really well. And women tell me that vaginal estrogen is magic across the ages. And it's such a small dose. If you use vaginal estrogen every day for 1 year, it's equivalent to 3.5 pumps of estrogen. That's not a lot. So 2 pumps is 50 and half a pump is 25. So you're talking 75 micrograms, and that's not a lot. It's in fact, it doesn't even get absorbed into the blood. So it is a lot. I call vaginal estrogen a low-lying fruit because technically speaking, it's not HRT, and many women can have access to that, even if it's contraindicated for other reasons. Even oncologists who treat breast cancer patients do say that that they can have vaginal estrogen, and it's transformational. And that brings me to another case of a 67-year-old that I reviewed. And she says to me, "Wow, I've got my life back, and now I don't need to go to the toilet every 2 hours. I don't have to wake up." To go to the toilet every 2 hours. I don't need to go shopping and then I leave my shopping and I go find the toilet. I used to know where the toilets are, where every toilet is because I'm off on and off to the toilet. So she tells me that she's sleeping better, and actually her symptoms had halved by the time I reviewed that. This was 3 months. This was a 3 months review, and she's feeling so much better. And she said to me, "You know what? I never want to be without HRT again." It's just the transformational effect of that. And sometimes women are told that you're too old, you can't have HRT. It's a case by case basis. If you're over 61 and you've been told that you cannot have hormones, speak to a doctor that understands, because there are symptoms that can be managed effectively, and you stop the suffering. We don't get our trophies for suffering. And when we get to our 60s, I'm 50, and at this phase of life, I'm like, I'll live longer, I'm gonna live. So if I'm gonna live a terrible life just because I'm afraid of maybe I'll get breast cancer, or this scaremongering that happens, you live a suboptimal lifestyle or a suboptimal life. And my other case was 48-year-old, tired all the time, can't sleep is a recurrent theme, tired all the time, cannot sleep. And there are three issues with sleep. Issue one is, or the presentation is, I cannot get to sleep. That's because they've got a busy brain, and also melatonin signaling is not great. Also serotonin. So serotonin goes up in the day and melatonin is low in the day. But at night, melatonin goes up because serotonin is the precursor to melatonin. So estrogen modulates both. So if you don't have estrogen, you don't have enough melatonin. And melatonin is the signal that tells the brain it's time to sleep. So melatonin is like the Olympic, the guy that has the 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 gun, when people are, running and boom, the gun goes, off you go. That is melatonin. It tells your brain, sleep time, everybody sleep time, switch off, switch off. So if you do not have your hormones, your brain does not know it's sleep time. So what happens? You're up. And instead of powering down to sleep, your brain is busy, 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 busy. But also, if we have anxiety, if we have poor sleep, if we are operating on sympathetic overdrive because we are just in this wired loop of anxiety. And by the way, anxiety, brain fog, those are the predominant symptoms of perimenopause. It's not, in fact, 1 in 4 women never get a hot flash, but every woman that I see either feels unloved, irritable, and has brain fog. So it's neurocognitive symptoms from head upwards. Okay, the other case was a 53-year-old. This is a review, and she's been my patient for a while, and she's been under the care of our other doctors. And our main issue is poor sleep, postnasal drip, and poor sleep. Waking up suddenly at 2 to 4 a.m., so early morning rising. Early morning rising is often related to histamine because histamine spikes at 2 to 4 in the morning. And often women with histamine problems tend to have vivid dreams. Also, they may wake up feeling anxious. They may wake up with palpitations. They may have morning nausea. And but in this case, every day she is waking up 2 to 4 in the morning, and she's had postnasal drip. So postnasal drip is common with histamine problems, and that's because the mast cells also produce leukotriene, which is a chemical that can cause symptoms of airway inflammation, including asthma. So she's got asthma as well. And so we manage that by really mast cell stabilizers. There are some medications that can be used for that, which I'm not allowed to read out to you because it will be seen as if I am treating you on the video. So if you want more information about how to manage your postnasal drip, your sinus symptoms, your asthma symptoms that are flaring, get in touch with me. I will be happy to help. Now I'm looking at my case note here, my case note, my piece of paper. And MSK, 45-year-old with musculoskeletal symptoms. She's got back pain and poor sleep and weight gain and exercise intolerance. She used to ride horses. She was very fit, and now she can't because she just has got lots and lots of pain. So she tells me that she went to her doctor, and her doctor said to her, "Go and exercise." So she was told, mark my words, this is what she said, we don't inhale weight. That's what she was told. You don't inhale weight. So then what happened? She goes and gets a personal trainer, and she goes hard at it and really exercising, and she tore one of her tendons. So that then knocked her back, and now she's feeling awful. She cannot lose weight anyway. She did not lose weight when she exercised. And you know why? At the basis of weight gain challenges is chronic inflammation. And when we talk about chronic inflammation, we are talking about your immune system. And when your immune system is up, the fight and flight system is up. And when you're in fight and flight system, you're in a fat storage state. So what happens is that your body is storing fat because cortisol goes up. And when cortisol goes up, insulin gets dysregulated as well. So then the primary instructions that your cells are getting is store fat, store fat, store fat. So to manage weight in perimenopause, menopause, address your inflammation. When you address inflammation, the weight loss follows. And I find that women who struggle with weight have got mast cell activation syndrome because the mast cells are the guard dog of your immune system. So and exercising more is not the solution, because when you're going very hard with cardiovascular running, running marathons and all that, that increases your cortisol. So it doesn't actually help us in perimenopause. We want more moderate exercise like walking, but also increase your heart rate. This intermittent training is good, but also improve your muscle mass. So why do we feel pain in perimenopause, menopause? Because estrogen goes down, and estrogen is a natural anti-inflammatory. Also, the lubrication of the joints. So we get this clickiness of joints. This lady was telling me a few days ago that when she bends her ankle, it just clicks, 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 clicks. And that is because of the lack of the natural anti-inflammatory effect of estrogen. Also, we start to get sarcopenia, which is where your muscles thin. So, and we are talking muscles, tendons, and ligaments. So they are a little bit more thin. They're a little bit looser, for lack of a better way to explain that. So then because of that, there's no support for your joint. So then you have this looseness of the joints, but also the aches and pains of the muscles as well. So that's why there is musculoskeletal pain. Actually, the stiffness that happens with perimenopause improves very, very quickly. And if I was to review a patient at 2 weeks or 3-4 weeks after being on hormones, and most of them say that the inflammation is getting better. However, if you got mast cell activation syndrome and you're not addressing that, the inflammation doesn't get better. Let me end here, guys. Let me end by saying that if you're not sure why you have all these symptoms of tiredness, brain fog, weight gain, aches and pains, high cholesterol, all these things going on, think about your inflammation. Think about your immune system. Think about your connective tissue, because women with looser connective tissue usually, often, I say 100% have mast cell activation syndrome. And when these mast cells are activated, the body is in a state of inflammation. So you feel off. A lady told me today that she feels out of sorts every day. She doesn't know how to describe that to anybody. So she just goes and says, "Can I have some blood tests? I don't feel great." And the blood tests are normal, and she still feels inflammation. So that's a snapshot of a menopause doctor. And stay tuned and send me some questions. I'd love to answer your questions. See you on the next video. Go well, everybody. Go well.